Good evening, Parth.
Hello, Dr. Pravin.
Hi, Rania. How are you doing?
I'm fine, and you?
Great. Very good. Very good. We are very excited for this specific program. I think there's a lot of interest. Thank you for making time in between your busy schedules.
Always a pleasure and honor to be with all of you. It's a great honor for me. And Hazem, he's sitting beside me. Just talk.
Hi, everyone.
Only 1 minute to start. Dr. Paris, are you going to start the introduction?
Yes.
Okay.
We'll have, I think I've shared the flow with Dr. Hazim, but I'll put it on the group as well.
Yeah.
Share the screen.
ما هي تقول شير اعمل شير.
Let me know, Shabina.
I'll play a countdown, ma'am. I'll just wait for a minute more.
Yeah.
As people are still joining.
Yeah.
اطلع بأول سلايد.
مش راضيين ما ينفعش لازم هم يدونا permission.
طب اطلع انت بأول سلايد انت بتشتغل. على فكرة انت ممكن تتكلم عشان صورتك تكون طالعة تتكلم لو عايز تدي نشكر.
Good evening, everyone. Greetings from Cornea Society of India for the new year. I am pleased to welcome you to the first virtual academic session of year 2025. As ophthalmologists specializing in cornea, retina, or any other specialty, we encounter complex cases involving pupil and iris abnormalities. These cases require meticulous planning, precise suturing, and delicate tissue handling. Today, we are privileged to have two esteemed international guest faculties from Cairo, Egypt, Professor Dr. Hazem Yassin and Professor Dr. Rania Shobi. They bring extensive expertise in this field and will guide us through a step-by-step video-based learning experience covering the entire spectrum of these challenging cases. At the same time, I would like to invite my co-coordinator, Dr. Gyan Mehdi, for being coordinating this session. And I also would like to invite CSI executive members as panelists. Plus, we do have two guest panelists, Dr. Gaurav Luthra from Dehradun and Dr. Rishi Swarup from Hyderabad, as part of the panel for discussion. With this, I would like to invite our current president, Dr. Praveen Krishna, to welcome you all. Dr. Praveen, please.
Hey, thanks a lot, Paras. And like you just heard Paras mention, the real stars of today's show are Dr. Rania and Dr. Hazem. And for those of you who've also attended KERAKONNECT recently and attended the instruction course on pupilloplasty, you would have probably heard that this is probably one of the best attended as well as most appreciated instruction courses. And like Dr. Paras mentioned, not just because of the fact that most people don't pay a lot of attention to iris repair as well as pupilloplasty, but also from the point of view of the passion as well as the interest in passing on what they know. So we welcome again two fantastic ophthalmologists from Egypt who have taken out time from their schedule and customized this course to an online version. And over to you, Dr. Rania and Dr. Hazem. I'm sure this is going to be an excellent webinar.
Can I just ask Dr. Gyan to introduce Dr. Rania first
Yeah.
to
Good
begin
evening.
the session?
On behalf of CSI, we welcome you all to this session of Masterclass. Our first speaker will be Dr. Rania Sobi. She is the professor of ophthalmology at Cairo University. She is also the deputy director of the Eye Bank of the Cairo University, Faculty of Medicine. She is a consultant, cornea consultant at International Eye Hospital, Dar Al Ayoun Hospital, Swiss Vision Center, Ghali Medical Group. With her vast background of anterior segment, corneal and refractive surgery, she had been sharing her experiences in various meetings across the globe. So we are very privileged here today to hear from her the steps and the background of doing a pupilloplasty and the anatomy related to it. Over to you, Dr. Rania. Dr. Rania, yeah.
Hi, good morning, everyone. It's an honor and a great pleasure to be here. I would like to thank Dr. Paris, Dr. Medhi, and Dr. Prabin for the great effort that you are doing for organizing this class. It's a great honor for me to be here. And I would like to thank everyone, Dr. Namrata and everyone here with us today. And I hope that the course will be beneficial to everyone and we can exchange our information and our knowledge together among all the expert ophthalmologists of the Cornea India Society.
I also want to express my thanks and gratitude to all the Cornea Society of India, the three showing musketeers here, Dr. Paras and Dr. Mehdi and Dr. Praveen, for giving us this honor. Actually, I consider India as my second home. The only thing which I don't like about India, then when I come back from India, I got like 20 kilograms over my weight.
So I'm going to start. It's okay, the screen now, Dr. Paris?
Yes, it's perfect.
Okay, great. I'm going to start and give an introduction about our course. As we all know that repair of iris defect, it's very challenging. It requires combination of visual, function, and cosmetic considerations. Iris reconstruction is like a puzzle. We are searching for the missing part of the iris. Either this missing part in the stroma of the iris, or in the root, or in this insertion, or in the function of the iris. After that, we reconstruct the pupil in order to have a well-centered, decent pupil. Why we do iris reconstruction? A lot of benefits are gained from iris repair. The amount of photophobia and glare decrease after iris reconstruction. The intraocular pressure might decrease in appositional angle closure glaucoma, angle closure plateau iris syndrome, Urey-Zavalia syndrome. In cases of endothelial keratoplasty, compartmentalization of the anterior chamber help to, after iris repair, we have two compartments. Also, iris repair will allow that prevent the recurrent optic captured in glued tilted intraocular lens. These are the benefits why we do iris repair. Before starting the repair, it's very important to revise the anatomy. As we all know, that iris is formed of a smooth posterior surface and a rough anterior surface. As we see here, it's divided by the collarette into inner pupillary and outer ciliary. The collarette represents the thickest part of the iris, and it's located about 2 millimeters from the pupillary margin. Also, there is iris raft and crepes in the anterior surface. Microscopically, the iris is formed of anterior limiting border, which represent condensed anterior stroma, where there is pigments. Then come the stroma, and the stroma formed of pigment and non-pigmented cell like fibroblast, fibroblast, mast cells, macrophage, and also there is muscles, there is connective tissue, and there is fibroblast. Then the anterior epithelial layer, which is formed of a single layer of myoepithelial cells. And the last layer is the posterior epithelial layer, which is formed of highly pigmented cells and is formed of a single layer of columnar cell. This is the microscopic appearance of the iris. Standard measurement of the iris should be revised. The diameter of the iris, which is 12 millimeter, the circumference of the iris, which is 37.5 millimeter. It's very important to know that the thickness of the iris root is 0.2 millimeter, which is different from the thickness at the collarette, which is 1 millimeter. The pupil diameter is variable from 1.2 to 9 millimeter, as well as the width of the sphincter muscle, which range from 0.6 to 0.9 millimeter. The thickness of the pigment epithelium is 12 micron during meiosis, which is different than mydriasis, which range from 50 to 60 micron. Vascular network of the iris is composed of a major arterial circle, which is located along the anterior portion of the ciliary body, and then the minor arterial circle, which run in a radial manner in the iris stroma, and it's responsible for the bleeding that happened during iris trauma. We have two muscles in the iris. We have the sphincter pupillary muscle, which run parallel to the pupil margin. And this supplied by parasympathetic stimulation, and its constriction causes constriction of the pupil. Then come the dilator pupillary muscle, which run in a radial manner, as we see here, and it's supplied by sympathetic nerve and cause dilatation of the pupil. The anatomical landmark, it's very important to study very well before starting the repair of the iris. Then the plan of treatment in the following steps. Step 1 is the preoperative evaluation. Step 2 is the analysis of the data collected. Step 3 is the choice of the surgical technique. As we all know that iris defect can occur either due to acquired or congenital lesion. And the acquired lesion can be due traumatic, as in blunt trauma, which lead to iridodialysis or mydriasis, or penetrating trauma can lead to iris tear, or iatrogenic after peripheral iridectomy, after glaucoma surgery, or collateral iris damage, which can obtain after cataract surgery. Also, it can be acquired for post-inflammatory, like post-angle closure glaucoma, post-infectious herpes zoster or herpes simplex. Then come the congenital causes, either coloboma or iridocorneal endothelial disease. These are the causes of iris defect. Preoperative evaluation, we have to spend a long time with the patient, trying to understand why the patient is here. Try to understand the symptom of the patient. She's coming for cosmetic purpose or for visual correction. So you have to take time asking the patient about the exact symptom of glare, of halos, photophobia, diplopia, and the reading problem. Then you have to ask her about history of ocular trauma and history of ocular disease as uveitis, surgical history of any attempt for repairing for the iris. Very important to ask about history of medication as alpha blockers or steroids. Then, after asking and talking to the patients, we have to do the best corrected visual acuity. When you do the best corrective visual acuity, pinhole test is a must. In order to simulate the reconstructed pupil, I'm going to reconstruct the pupil, so I'm going to give an idea to the patient. This will be your vision after reconstruction of the pupil. After that, we start to examine the patient. Slit lamp examination is very important, and you have to take anterior segment photography for the patient before starting to repair the iris. You have to have a pen in order to draw the shape of the iris. First, you have to examine the iris and to check the severity of the iris laceration, and then the presence of iridodialysis. And then you have to check the quality and the quantity of the remaining iris tissue. You have to check if this remaining iris tissue is good to do and start iris repair or not. You have to check for the presence of iris atrophy. And you have to check for the trans-illumination defects, big or small defect. You have to exclude the presence of synechia. Also, you have to check there is retroflexion or anti-flexion in the iris. And after we finish examination the eye with the iris problem, we have to check the other eye to exclude the presence of exfoliative material along the pupillary margin. And after we draw the iris and all the details of the iris should be noted, we start to examine the pupil. What we are going to see in the pupil? We need to know the size and the site of the pupil. The presence of sphincteric tear and the presence of neovascularization. I may need to give the patient anti-VEGF during the iris repair. The presence of ectropion UV. All these very important to know and to check and to document before starting your repair. After that, I have to check the anterior chamber. I have to exclude the presence of any synechia in the anterior chamber. I have to exclude the presence of vitreous. After I finish the anterior chamber examination, very important to check the condition of the lens. If the patient is phakic or pseudophakic, and you have to check the stability, the instability of the lens bag zonule complex. Why? If I'm going to put an iris implant, I have to make sure that the bag is stable, there is no subluxation, especially if this patient has a history of ocular trauma. And then come the gonioscopy. We have to do gonioscopy to exclude the extent, to exclude the presence of peripheral anterior synechia, and to study and to document the extent of dialysis in cases of iridodialysis. After I put all the image for the iris, in order to always put in mind, are the different type of the iris defect that we may have. Then I'm asking myself, is all iris defect can be repaired? The answer is yes. All causes for iris defect can be repaired. Congenital, yes, we can do repair for colobomas, polychoria, and aniridia. In cases of mydriasis, either traumatic mydriasis or neurogenic mydriasis. In case of Urey-Zavalia syndrome. In cases of iridoplasty for angle closure, glaucoma, and TAS. Traumatic iris defect, all type of traumatic iris defect, either iatrogenic defect due to big peripheral iridectomy in the past or traumatic iris defect. Pinhole pupil optics, in cases of RK or very high irregular astigmatism, we can do pupilloplasty simulating the pinhole in order to decrease the amount of astigmatism in irregular corneas. And in endothelial keratoplasty, yes, with the iris reconstruction, we can do compartmentalization of the anterior chamber in order to help unfolding our DMAC or the sac tissue. After that, we have to know which iris defect are we going to deal. First, we have to know the size of the defect. If the defect is less than 2 hours or more than 2 hours, because this will change our plan of surgery. Then the shape of the defect is a sectorial defect, or the defect in the form of dilated fixed pupil, or the defect in the root of the iris in the form of iridodialysis. Then the third point, I'm going to do iris repair in a light blue iris or thick brown iris. As we all know that the incidence of cheese wiring will be higher in light blue iris than a thick brown iris. I have to know this before starting the repair. I'm going to do a repair for a single or multiple defect. And then you have to see the remaining iris tissue, because this will affect our decision in which surgical technique I'm going to do. The character of the remaining iris tissue, the transillumination defect in the remaining iris tissue, the delamination and the fraying of the iris surface in the rest remaining iris tissue, the presence of rubeosis, all these points should be checked. And the remaining iris tissue in the collarette or in the mid-periphery, because this will change our decision in surgery. After that, studying the iris defect, I have to ask myself, I'm going to do the iris defect alone or with other surgery. Other surgery like the cataract surgery or glaucoma surgery or penetrating keratoplasty, part of penetrating keratoplasty, or I'm going to do DMAC with iris reconstruction. So I have to know all this and plan it before starting the iris repair. And then after all my data with me, after staying and collecting the data and spending time with the patients, I have to put my plan. What is my plan? My plan, either I'm going to do iris reconstruction alone or iris reconstruction with pupilloplasty. So iris alone, pupil alone, or both together. So the decision now, if I'm going to do iridoplasty alone, so I have to know, is it tissue loss or functional loss in the iris? If this is a functional loss, so I will go to put iris prosthesis. If the loss is tissue loss, so I have to see if we don't have no iris at all, total aniresia, so my decision will be put iris prosthesis. If the defect is sectorial, where in the iris root in the form of cyclodialysis, so I have to suture the iris. And suturing which type? I have to suturing the iris matrix suture. Okay, and after that, if I have a stromal tissue loss, I have to ask myself, less than 2 hours, and the remaining iris tissue is healthy, of non-proliferative etiology, so I have to suture this iris. Which type of suture? Sipser, modified McCannell suture, intraocular sutures. Any type of suture I can use. But if the stromal tissue loss more than 2 hours and the remaining iris tissue is not enough, or of atrophic or thin etiology, what I'm going to do is I'm going to put endocapsular prosthesis together with iris suture. Or I can put a scleral fixated prosthesis together with iris suture. After I finish the iris repair, I will shift to do the pupillary repair. What I'm going to do in the pupilloplasty? If the size of the pupil is big and dilated, I have to constrict it by taking a suture, which is a cerclage operation. Cerclage taking suture in order to decrease the size of the pupil. If the location of the iris is Z-centered, I can do argon laser pupilloplasty or diathermy shrinkage in order to centralize the iris. Oh, sorry. If the pupil is malformed, what I'm going to do is to take suturing, Sipser sliding suture or single pass for through. And this is the plan for reconstruction. So now you have a case of iris defect, you have to plan it, and this is the scheme to summarize all the iris defect. Thank you so much. I will give now the talk to Dr. Hazem to show the video and speak about the basic suture technique.
Thank you, Dr. Rania. Yeah, may I call upon Dr. Rishi is there?
Yeah, Dr. Hazem is here. Yeah.
Dr. Rishi?
Hi,
Hi,
everyone.
Dr. Mehdi.
I'm here.
How are you?
Hi, Dr. Hazem.
Hi, Dr. Swarib. How are you?
Good to see you.
Rishi, your comments on the Dr. Rania's talk?
So I think that
Yeah.
was a fabulous, Dr. Rania. Thank you. You really covered the basics of iris and pupillary repair very nicely, and how to approach a patient with defects or functional problems with the iris and pupil. I think there's really nothing much one can add to that. It was very, very comprehensive, and you've kind of set this ball rolling for the next talk, which I think is going to be the main course. My only addition to this probably would be that if we are dealing with a phakic lens versus a pseudophakic eye, maybe we have a slightly different approach, and especially if we are thinking of preserving the lens. So that's probably the only other thing that I would add. Otherwise, it was very nicely covered in a very systematic way. And you mentioned rubiosis, but in a rubiotic eye, I think most of these measures really would be difficult to implement. And you may probably only, argon laser would probably the only approach one would possibly consider, and not any suturing kind of techniques in a uveitic or an inflamed eye.
Okay. Thank you, Rishi. Dr. Paras, would you like
Yes,
to introduce?
yes, Dr. Gilan. Before we move on to Dr. Hazem's talk, I would like to introduce him. Dr. Hazem Yassin is a professor at Cairo University. He is highly accomplished ophthalmologist with over 30 years of experience. He has renowned author and editor of a popular Arabic book on eye diseases. That is very unique, Dr. Hazem. And he's also dedicated to humanitarian work as a founder of the Hazem Yassin Foundation, providing free eye care services to underprivileged patients. He is an internationally recognized instructor and contributor to the field of ophthalmology. I welcome you, Dr. Hazem, once again to initiate your talks, video-based talks.
Well, thank you very much, Dr. Paras. I really appreciate your introduction, and at the same time, I'm again repeating my gratitude to the Cornea India Society, which I think it's the most educating and informative cornea society all over the world. So it's leading now, and I always encourage my younger colleagues to go learn in India. Without further introduction, we're going to talk about some surgical things. So we're going to talk about the surgical principles of the iris construction. We need to have a small incision, so closed system. We need to have some sort of mobilization so that we can free the iris tissue as much as possible. We have to release all the peripheral anterior synechiae and posterior synechiae at the same time. We have to know many things about the knot tying and the intraocular sutures for pupillary repair. we have to know the concept which is really forgotten, the retroflexion and the antiflexion in iridodialysis repair. For the iridodialysis repair, we're going to discuss the reattachment of the ciliary border of the iris to the sclera. And of course, if we have time, we can talk about the iris prosthesis. So these are the reconstruction techniques. I'm not going to waste time in this slide because we're going to talk about them in the next following slides. For the checklist of the instruments, we need to have needle 10-0 Prolene suture, microgastric forceps, blunt tip spatulas, micro scissors, Sinskey hook, AC maintainers, viscoelastic, 25 gauge needles, retractor, angle, trying forceps, and endodiathermy. We are going to discuss later on that in a way or another, we are kind of like, it's unfair for us being surgeons, because for the needle itself, if it's passing through a soft tissue, it should be rounded tip needle. And for that of the hard tissue, it should be cutting and beveled and pointed. So we need a needle with a dual behavior. When it passes through the iris, which is considered as a soft tissue, it should be not cutting. And when it passes through the sclera, it should be cutting. What are the types of the iris repair? We are going to discuss the total posterior synechia and ring synechia, pupillary border sutures with cerclage with iris atrophy and without iris atrophy, combined iridodialysis repair with pupillary cerclage, changing the pupil location, pinpoint pupilloplasty, and if there's enough time, we'll talk about the iris prosthesis. So sometimes the iris surgery is freeing iridocapsular adhesions. For such a case, there is a difference between ring synechia and total posterior synechia. In ring synechia, there will be shallowing of the anterior chamber and iris bombay. Meanwhile, total posterior synechia means there is adherence between the iris and the lens capsule from the pupillary border till the ciliary border. So this means that we have a very deep anterior chamber, and we need to separate and create a sulcus space so that we can put an intraocular lens. Well, I consider this one of the very challenging iris surgery procedures, because you have to cut flush between the iris and the capsule in order to prepare for your intraocular lens to be put in the sulcus. Sometimes in eye syndrome, and I'm considering myself right now as a regular cataract surgeon. And for a regular cataract surgeon, eye syndrome to remove a cataract is quite challenging. Why? Because as you see here, we have peripheral anterior synechia 360 degrees. And I need to find a place where I can put the side ports and my incision. And I want you to notice now what will happen here. If I'm a regular cataract surgeon and I'm not prepared with a DMAC tissue, I want you to notice now, can you see this? Now I induced iatrogenic detachment of the descemet or the descemet membrane from the back of the cornea. So if I'm a regular cataract surgeon, then I will be trapped in this situation with post-operative corneal edema. And as you see here, the descemet tissue is attached to the iridoscetic iris and towards the angle. So we need to visualize this membrane, and we need to cut it flush together from the surface of the iris by cutting all the iridoscetic tissue from above the iris. Of course, due to many maneuvers in the anterior chamber, there will be fibrinous adhesions. And these fibrinous adhesions, if I'm going to implant a DMAC tissue, it will hinder the opening of the DMAC tissue. So I have to inject triamcinolone into the anterior chamber in order to visualize all the fibrinous.
I think the video is also coming a little broken, isn't it, Dr. Paras?
Yes, it seems we have lost him for a while. Dr. Hazim, are you there?
I'm there, yes. Can you hear me?
Yeah, yes, but the streaming of the video is very slow. Can you ask the technical guy to kind of help us with the video?
Can you see? Is it progressing?
Yes, we can see. We can see the video, but it's moving at a very slow pace, or hardly moving, I would say.
Do you think that this is a Wi-Fi problem?
Maybe you have to optimize for video sharing. Did you do that when you were doing screen sharing?
You can do that again, Dr. Hazem. If
Yeah,
that is
okay.
not done, you can optimize the video sharing. That would help in seamless streaming of the video, as Dr. Rishi is suggesting.
Okay.
I guess the file is heavy. That's why it is happening like this.
Yeah, 6 giga.
I think you need to play the video. It is on a pause. Yes.
So now it's working.
Yeah. Better than before. Yeah, you can go on.
So what I wanted to say about that is that you have to cut flush over the surface of the iridoschitic iris and then inject triamcinolone in the anterior chamber to make sure that everything is kind of like really ready for the DMEC tissue in order to inject it and to prevent unfolding of the DMEC tissue. But what I want to say here is try to make the diameter of your DMEC tissue narrower than the edges where the peripheral anterior synechiae are there, because otherwise the peripheral anterior synechiae will recur no matter what you're doing. So we can see here that with the pulling of the iris tissue, I can have some sort of formed anterior chamber, probably even control the intraocular pressure. Sometimes we have a persistent pupillary membrane. And for this patient, if you see, can you see the video?
Yes, Dr. Hazem.
It's working.
So this is a persistent pupillary membrane, and we need to maintain the clarity of the lens because this is a pediatric age grouping, and the persistent pupillary membrane is adherent to the capsule. So I'm injecting the viscoelastic behind the surface of the iris so that it will do some sort of like a parachute action, and it will do some sort of mechanical separation of the pupillary membrane away from the capsule. Why? Because this pediatric age grouping, the patient came with no autoref reading, irrefractable, and immediately after post-operative, like 1 week post-operative with the clarity of the cornea, the patient had a vision of 0.6 from counting fingers 90 centimeters to 0.6. And here you can appreciate that at the end of the separation of the membrane, you can see that there is a red reflex and crystal clear lens. So you need to invest some time in order to maintain and preserve this lens for the accommodation and for everything like good clarity without implanting an intraocular. Now you can appreciate the red reflex and the clear lens. Now we're going to talk about the basic suturing techniques. For this slide, when McCannell introduced in the 70s the first iris suture, there was a problem here. What was that? The problem is that we used to open the incision with a scalpel knife, 15 scalpel knife, and then you pass the suture from one side of the iris to the other side of the iris. Now both ends will be exteriorized. If you try here to not, what happens is that the iris will be exteriorized outside the anterior chamber, which is not anatomical, okay? So this is why it was hindered due to the absence of MVRs, of the side ports incision, and of the keratome incision. Then later on, there was modified, Ike Ahmed modified the McCannell suture by introducing one end of the suture inside the anterior chamber. So unlike this one, I'm not going to exteriorize the iris. I'm going to introduce one of the ends of the suture after the knot to be inside the anterior chamber, so that when I pull, it will be 180 degrees opposite each other, and the knot will be introduced inside the eye. We will know more when we know about Ogawa. Ogawa introduced again one wound but sliding knot. So Ogawa now is exteriorizing both ends of the thread, and will take the throw, and then he will push this knot by a Sinsky hook inside the anterior chamber, as you see. So when this happens, I'm interiorizing the knot to the iris tissue, not like McCannell exteriorizing the iris away or outside the anterior chamber. This is the schematic, and then when we are going to show it in the eye, like in operation, this is the knot, and now I'm exteriorizing, getting both ends outside. Then I will take both ends of the threads and I will push the knot towards the iris tissue. As you see, these are one wounds, like in McCannell and Ogawa, one wound. Then came Sipser, who thought about two wounds 180 degrees opposite each other. So now this is one wound and this is the other wound. They are 180 degrees opposite each other. I'm going to exteriorize a loop, then take 3 throws, and now the loop is sliding inside, but two wounds opposite each other. This is the difference between Ogawa McCannell and Sipser. Is it showing properly? Dr. Paras?
Yes, Dr. Hazim. It's
Okay.
absolutely. Yeah.
So now, after the 3 throws of Sipser, came the Agarwal group, and they thought about single 4-throw pupilloplasty. It's a modification of Sipser because there is the explantation. Now the iris will, the knot will go through the iris, upper surface, lower surface, lower surface, upper surface, then outside the eye. And I'm going to exteriorize a loop. And once I exteriorize the loop, I will take 4 throws. Well, if you think about it, for the 4 throws, it's not an actual knot, it's a helical thing. It's not a knot. So what is the difference? If you have an aphakia, or you don't have a posterior chamber IOL, if you have a bottle height which is very high, this will stretch the iris level, will go backward, and this will stretch the helical thing, and it will be disengaged. So please don't do the single 4-throw unless you have a retroiridial support, whether with a crystalline lens or with an implanted intraocular lens. So for us as corneal surgeons, we will think about compartmentalization of the anterior chamber for those who have big iris defect, and we are afraid of having the implanted tissue to go behind the iris into the posterior segment. So for us as corneal surgeons, we should know the iris surgery properly. Again, this is repetition of the same thing. And then after cutting, I'm introducing my DMEC tissue. The same as repetition of the main thing. Now I'm doing the DMEC tissue in a previous penetrating keratoplasty. We knew now the mecanal which is not anymore used, either Ogwa, Sipser, or single fourth row, or modified Ike of mecanal. These are the 4 sutures which we are using for the pupillary border. I'm going to repeat every now and then. The mecanal is not used anymore. What is used is either Sipser or single fourth row or Ike modification and sometimes Ogwa. Now we'll talk about the iris cyst, which is one of the very resistant and struggling tissue, and you have 2 ways of dealing with them. Either intralesional alcohol, 70% with an OCT guided microscope, which is not available in every facility, but let's talk about the excision and resuturing. So for this eye, you can see here that there is a previous ruptured globe. And we usually, at least in my country, we leave the ruptured globe for young residents, junior residents, to do the repair. But if the repair is not done in a proper way, the iris will be adherent to the back of the repaired ruptured globe. And if there is defects now, the epithelium of the cornea will go over the surface of the iris, inducing this big iris cyst. So for this big iris cyst, I have to excise as much as I can of the iris tissue, up to the level that I'm going to excise even normal iris tissue, like the old historical white basal iridectomy. So I'm going to excise from here till here, a very big part of the iris tissue, even a normal iris tissue, in order to prevent the recurrence. Always remember that the rest of the iris cyst is entangled into the angle, and if it's present there, it will recur. So I have to dramatically remove them, aggressively remove even iris tissue. So after doing that, I'm going to have my interrupted sutures, implanting my posterior chamber IOL, and then taking my iris sutures, restoring the pupil first, the pupillary margin, and then all these maneuvers will be shown later on. I'm closing everything, all interrupted sutures, and leave the patient even with more interrupted sutures, and I'm going to close all the defects, because if I'm leaving small defects, it will act like correctopia. So the patient is coming with a complaint of ghost images. And I can use the cutter like I'm doing here in order to fashion the pupil, but I'm going to talk about this later on. And this is the first operation. Later on, I'm preparing for endothelial keratoplasty.
Dr. Hazim?
Yes?
Did this needle come out through the cornea in the previous case?
I beg your pardon?
Did the needle come out through the cornea as you were suturing the iris? In this case? Did the needle come out through the cornea?
No, it was, no, it is not. Yeah, from this side, yes, you can go out through the cornea. But where you're going to explant the loop, then it should be a fresh wound.
Okay.
I will show you later on. Sometimes I have the iris surgery because I did an iatrogenic mistake. So I'm obliged to do a procedures. In such a case, I'm preparing for Yamani, and I'm preparing for a big wound like here in order to explant my subluxated or dislocated mature cataract. I'm implanting a Boris Malugan ring, very resistant pupil, very rigid pupil. I found myself entangled in a situation that this Boris Malugan ring is 6.25. millimeter, and I'm fighting with the Boris-Maluga ring in order to open this pupillary membrane, this pupil, which is very stubborn, as you see. And for such a case, the lens is subluxated, is mature and subluxated. I'm going to exchange my Boris-Maluga ring because it was used before, and I'm going to put a new one, succeeding eventually in inserting the Boris-Maluga ring. But always remember that Boris-Maluga ring comes in two sizes, size 6.25 millimeter, and the other size is the 7 millimeter. Now I introduce my vectis in order to get the lens, but as you see, everything now is obstructed, like the vectis and the nucleus are obstructed in the 6 millimeters Boris-Maluga ring. And now I'm praying that I could have been a gynecologist in order to do episiotomy for this Boris-Maluga ring. Everything is entangled inside the anterior chamber. Then I have nothing to do except using a scissor in order to cut. Now my left hand is entangled into the anterior chamber and everything is inside the eye. And then I have to cut the Boris-Maluga ring, amputate it in order to get it outside. And if you can see here that there is an iris trauma. So can you see this iris defect? This is an iatrogenic tear. So if you are a cataract surgeon and you don't know the principles of doing iris surgery, then you should know it, because you might be subjected to such a situation, especially that the tear in the iris is present in the lower nasal part. So all of us, we have to learn the iris surgery. I'm preparing for my Yamani implanting. And then after doing the flanging, I will do the pupilloplasty in the same concept, okay? Sometimes I have this subluxation, traumatic subluxation. I'm trying to save the bag because this is a sunset appearance of subluxated traumatic subluxation, and everything is at 6 o'clock. So I'm putting, you have to check the caliber because we don't check the tip of the caliber. Now I'm implanting my Ike segment. This is actually from Madhu, a very nice Indian company, and it's called Gupta and Canabrava Ike segment. As you see, the eyelet is above the iris because the outer bent caliber, it was not 2 millimeters. So in such a situation, I have to bring the eyelet over the anterior capsule, not over the iris. So this is, it was an iatrogenic mistake. So I might be obliged to know the concepts of the iris surgery in order to correct this iris and bring the iris leaflets above the eyelet of the Ike segment or the Gupta segment. Then correcting it in the usual manner. Then came Sayoni, and Sayoni was talking about the iris coloboma. And in such a schematic, we are taking an incision in the iris nearby the iris root so that we have a rotational flap, and this rotational flap will be attached to this border of the pupil, and then we will deal with that like an iridodialysis. Now we are going to talk about the iris cerclage. For the iris cerclage, I have to have 4 keratome incisions in the oblique axis. So one here, upper temporal, and then here, lower temporal, lower nasal, upper nasal, okay? And then I will take in each quadrant 4 to 6 bites, baseball bites, and then I'm going to exteriorize the needle here. Then go again, do 4 to 6 bites in the going quadrant, and then exteriorize here, and then following third quadrant, and then we will show you in the next coming one. It's either we have pupillary cerclage but without iris atrophy, and if there is no iris atrophy with traumatic mydriasis, this means that the pupil is stretchable and the iris tissue is stretchable. So for I have to sequester the vitreous band here, the vitreous surface here. Otherwise, the stain will go into the vitreous cavity, and is extremely important. Then you have to close it. Otherwise, if the stain goes into the vitreous cavity, you will lose the red reflex. I have to stain it in order to change the behavior and the characteristics of the capsule itself. So I'm doing the rexes. As you see, I'm holding the capsulorhexis forceps and doing controlled centralized capsulorhexis, because this, if I succeed in that, everything will be easier later on. So for this capsular hook, it's not an iris hook, it's a capsular hook. So there is, in the design and the fashion of the capsular hook, it goes into the equator of the bag. And for that, I have to keep the bottle height low, because if the bottle height is very high, this will push the bag apparatus backward and it will be disengaged, as I'm showing here, because I didn't know this trick. And then I'm going to implant my CTR. If you see this second instrument, I'm holding the leading eyelet inside, so that is not inducing more trauma to the ciliary, to the zonules. And then eventually I have to make sure that I'm inside the capsulorhexis, otherwise it might go above the capsulorhexis. The trailing haptic might go in above the capsulorhexis. So now, as you see, I'm in every now and then, because the height is very high, so I am inserting the capsular support again. For the last quadrant, I'm going to leave it and use the concept of Amara Agrawal of the IOL scaffold. So I'm going to implant the IOL first in the bag. This will protect the posterior capsule. Why? Because the posterior capsule is like a flutter. It will move. And of course, you can see that here, there is a posterior capsule opacity. Please refrain from touching the posterior capsule if you have a CTR. Otherwise, the vectrum of the CTR will work like extending any tear in the posterior capsule, and you will never be successful in getting a posterior capsulorhexis. So I'm leaving that later on for YEG. Now I'm removing my capsule support system, putting my Gupta of Madhu. Of course, I have no financial interest or disclosure to disclose. For this, it's made of a body and an eyelet. So the eyelet is above the plane or the level of the eye segment or the Gupta segment, which means that the body will be inside the bag, but the eyelet is above the anterior capsule in order to anchor it to the level of the sclera, so that you're inducing some sort of artificial zonules. So I'm passing it through the hole, and then I will exteriorize it outside, and then I'm going to go back like a mattress suture, so that by this way I'm anchoring the bag into the sclera, artificial zonule. Okay? As far as I finished my bag job description, now I'm going to go for the pupilloplasty. So now I will have 4 openings, one here, one there, one there, and one there. Fixing the bag in a centralized way. It doesn't have to be that tight. You're just hanging the bag. So now you will see me opening the 4 quadrants opening. It shouldn't be at 12, 6, 9, and 3. It should be upper obliques in the upper temporal, lower temporal, lower nasal and upper nasal. So now we will see that we'll start from this opening. Now I'm testing the behavior of my iris. So as you see, I'm stretching it in order to see how stretchable it's going to be done. And these are the four openings, and I'm doing the baseball suturing technique. I want you to see here, when I'm going to exteriorize the needle from this part, I'm very afraid to catch or to fish through a corneal tissue. So for this part, I'm going to introduce my viscoelastic cannula, and I'm going to insert the tip of the needle as shown here now in a second. I'm feeding it inside the viscoelastic cannula. So I'm dead sure that it will never catch a part of the corneal tissue. Otherwise, if you're going to interiorize it, you will never be able to do the cerclage. Take again 4 to 6 bites and then exteriorize it from here. Okay? For the sake of time, I'm going to fast forward. And I'm going to stop here. Now I exteriorized this part. I will stop here. If you see, I went 3 quadrants, 1, 2, 3, anti-clockwise. Because my thread is double needled, this means that, and I'm right-handed surgeon, so I'm going to use the other needle for the remaining quadrant, but in a clockwise fashion, in a clockwise manner, which means I started upper temporal, but now I'm going to exteriorize this needle from an upper nasal quadrant, okay, from an upper nasal opening. I started in one opening, but I will finish in the adjacent opening. And once I did that, I will go outside, feed it inside the viscoelastic, and get the 2 ends from this wound. Now I want you to train yourself. If I'm going to do the throws and then pull to the outside, this is mechanical, and which means that the iris will be exteriorized outside the anterior chamber, okay? If I'm going to have the throws and then interiorize the knot inside, it is Ogawa. And if I'm going to interiorize one of the ends of the thread opposite this direction, this would be Ike modification of mechanical, okay? So I'm narrowing but not exteriorizing the iris. I will have the knot in a slip way, and then I will use a Sinskey hook in order to interiorize, as you see. Now it's Ogawa, and then I will take one of the sutures between Ogawa in order to get the proper sizing of the iris, okay? If I have a pupillary cerclage with an iris atrophy like this is a case of combined glaucoma and cataract surgery together with pupilloplasty. But we have here a phase of iris atrophy. So for this case, without further repetition, after implanting my intraocular lens, if I pull here, there is no problem. But if I pull nearby the atrophic iris, this means that I'm about to do an iatrogenic iris iridodialysis because I'm pulling on the iris root. So there will be immediate hyphema here. You have to stop. Okay. For stoppage of bleeding into the anterior chamber, I should use both things. Injecting the air bubble is kind of like high dehydration or drying of the blood clot, which means that the blood clot, because of the air, will be clotted. The fresh blood will be clotted. But it's not for pressurizing the anterior chamber. For pressurizing the anterior chamber, you should use a viscoadaptive something like Helon or something like sodium hyaluronate in order to pressurize the anterior chamber and raise the pressure inside the anterior chamber. So use both air plus the viscoadaptive. So here I'm sequestering the bleeding. Then I will continue stretching my iris. If I detect that my needle is one straight and the other one is curved, then I have to change my location, like what I'm doing here. 4 quadrants, and then I found out in the last quadrant that the straight needle is only one and the other needle is curved. So I had to exchange my location so that now you can see the trabeculectomy flap is on the left side. So at this moment, I have to exteriorize from the original incision. Okay? And I can tighten. All these defects can be closed. Okay? What do you think about after doing the cerclage? If you're going to do the superior iridectomy, the peripheral iridectomy, if you're going to drag on the iris here, this means that there will be cheese wiring because you have a pupilloplasty. So for such a case, you have to continue your upper iridectomy through the block with the vitrectomy. Never pull on the iris after the pupillary cerclage you did. For those defects, the patient comes and complains of chorectopia. So it means that the surgeon was not patient enough to take many bites. So before doing your locking knot here, take an interrupted suture between these two ends so that you can close it before you do the final tying of the cerclage. What determines the cheese wiring? Is not only the friable tissue, because you're going to take sutures in non-transibulating tissue, but we have to free all the adhesions, whether posterior synechia or anterior synechia, and we're going to test for the stretchability of the iris tissue in order to check the behavior by mechanical pulling. The tissue resistance and dragging regarding the needle, because it's very unfair, the needles which we are using and the monofilament threads. The atrophic depigmented tissue, well, we have to avoid cerclage as we are going to show in a few slides, and avoid 180 degrees edge-to-edge approximation. We are going to do adjacent hour-to-hour interrupted suture approximation as will be shown in the following slides. So in such a case, I'm approaching this hour to this hour. And this hour to this hour, I'm not doing cerclage. And this is an adopted technique in cases where you have iridodialysis together with traumatic mydriasis. Now, for the traffic jamming of a knot, if you keep the knot over the surface of the iris, there will be traffic jamming, whether on this side or this side. So you have to have this movement of your iris tissue or your thread so that it will always be in the middle between the two edges of the iris tissue. If you're going to pull on the iris, so the pulling of the iris should be from the pupillary border, not from the ciliary border. Otherwise, you will induce iatrogenic iris dialysis. So always remember that any dilated iris is like a curtain, and this curtain is folded over the angle into the anterior chamber angle. So you need to milk the undersurface of the iris so that you can pull it from the pupillary border. Now, many of us, we have some sort of Uret-Zavalia syndrome after DALC. And this is, as you see, kind of like atrophic iris. Honestly speaking, nowadays, I don't do pupillary cerclage for these cases. For these cases, I go and do 1 hour to 1 hour approximation. So, for example, this hour to this hour and this hour to this hour, so that I can narrow the circumference of the pupil itself. So I don't do any more cerclage for these cases. I don't want to repeat myself. It's the same concept of the cerclage. Sometimes we are faced with an open sky cerclage where you are, when you remove your graft, you will find that the pupil and the pupil is dilated and the lens is projecting. So you will do vitrectomy, and then you can, why I'm showing this case, because this case is done with the monofilament and is not with Prolene. And believe it or not, is not right, what is written in the textbooks. There is no biodegradation. This patient, I'm following her up like right now for almost 10 years, and the pupil is still the same.
Dr. Hazim, can I interrupt you for a while?
Yeah, sure.
I just wanted to know that when you are doing an open sky pupilloplasty, as we do it in penetrating keratoplasty, as you have shown here, where would you keep your suture knots? Would you keep it buried, or you would like to, keep it on the surface of the iris?
For the sake of time, I didn't show that I changed my direction of the needle. But what is most important, if you start from the undersurface of the iris, so this is the iris. I'm trying to show here. If this is the iris, I'm going to start from the undersurface of the iris, and then take the bites and finish on the undersurface of the iris. So when you constrict your suture, it will be hidden from the undersurface of the iris for fear of leaving anything that it might endanger the endothelium. So start on the undersurface of the iris and finish on the undersurface of the iris. So when you tighten, the knot will be on the back surface of the iris. How to
Dr.
examine the fundus? Go ahead.
Dr. Hazim, we have another fantastic surgeon with us today, Dr. Gaurav Luthra from Dehradun. He's a cataract refractive surgeon.
Known.
And I would like to invite some comments about the previous cases from him. Dr. Gaurav, please.
Yeah, thanks, Dr. Paris, and thanks, Dr. Mehdi and Cornea Society. And I'm amazed, the videos have been fantastic, Dr. Yasin, and I've enjoyed all your videos, including all the pearls that you've given about the capsular hooks, about the Malugin's ring, and about the iris suturing. So you have the whole repertoire. And I think I agree with you that the Malugin's ring, sometimes if you have a bit of a distortion of the ring and it catches the iris, it can cause a lot of iris damage, as you showed very nicely. So one has to be extremely careful about that. And also, I was very happy to hear your other comment about the capsular hook, because many times beginners, first of all, these capsular hooks are really amazing. The MST hooks, and especially with the modification that has been done by IKE for the MST capsular hooks, where they have kind of decreased the peripheral part so that the it doesn't catch. In the past, it used to happen that if you were passing a CTR, it would go through the hook sometimes, and then you would have an entanglement. So they modified the design. So I think all those pearls have been really amazing, and your surgeries are self-explanatory. You're doing a great job. So I don't have really more to say except that enjoy what you're showing, and thank you for inviting me.
Thank you very much. So how to examine the fundus after pupilloplasty? Now there is the Nikon Optus. Of course, I have no financial disclosure or interest. So it's examining the pupil through 2 millimeters, examining the retina through 2 millimeters, okay? So this is for the outpatient clinic examination and to see the periphery of the retina. But what if retropupillary maneuver is needed after the cerclage? Please do not induce iatrogenic cheese wiring by delivering an IOL from a posterior segment through a suture-fixed pupilloplasty. Otherwise, the pupil will be damaged. So for such a case, the pupil is, the surgeon is trying to push it through the pupilloplasty. It will never go. You have to cut this pupillary cerclage. Once you cut the pupillary cerclage, the pupil will open with a viscoelastic. So after exchanging the lens, now you can repeat your pupillary cerclage again. So the message to here is never try to push the lens from behind to forward. No, cut the pupillary cerclage and then expose the lens into the anterior chamber and then do the pupillary cerclage again. Now we're talking about the iridodialysis, and we're not going to repeat ourselves regarding the sutures. So the iridodialysis repair by the hang-back technique is extremely important, and I shout in every conference why the concept of retroflexion and antiflexion is missed and forgotten. So for any iridodialysis, which is more than 3 hours, there is either one of two things. Either the anterior surface of the iris is curved backward, like a cannelloni, so this is a retroflexion, or the posterior surface of the iris is looking to the back of the cornea, which is antiflexion. Let's see these cases. So iridodialysis repair, the retroflexion is the key. Now, any more than 3 hours iridodialysis, either the anterior surface looks backward or the posterior surface looks forward. If I don't know this, I will assume that this is the pupillary border of, this is the ciliary border of the iris, not this one. So if I'm not taking the sutures here and I'm taking the sutures here, what will happen is pupillary migration. I will explain what will happen if you have this pupillary migration. Now, this edge of the folded iris will migrate to the limbus. Now, the surgeon doesn't know anything about the retroflexion concept. So he's assuming that this is the ciliary border. It is the folded border of the iris. Notice the pupil migration. Now the surgeon is going to correct this by another suture here, and the disaster is coming. Now you can hear the sirens of the ambulance because the surgeon is having kind of like cardiac arrest of what is happening here. Why? The surgeon didn't know about the retroflexion concept. So for such a case, here is a case where the iris is retroflexed. It's like a cannelloni. It's a blunt trauma. And I know that the iris tissue is there, but it's hiding. It's kind of like a shy iris. It's hiding from me. Now I'm going to tease the undersurface of the iris in order to correct this cannelloni style. I'm going to unfold this undersurface of the iris so that I can stretch it. This is a schematic showing that I'm correcting the undersurface of the iris, and then I'm taking my matrix sutures or sewing machine suture or whatever. So I'm here stretching as much as possible, correcting the retroflexion, and exposing as much as possible iris tissue, stretching it correcting the undersurface, removing all the vitreous bands, and then opening my battle field for the scleral flaps. You can have it here like a groove, or you can prepare for many flaps like this. Some of my colleagues asked, do you put AC maintainer or pars plana infusion cannula? Of course, AC maintainer will allow you in order to change the location, and then you will take the matrix sutures. As you see here, it was there, the AC maintainer, now it's here, and it's extremely important. When you pass through the iris, you need a switch on line so that the tissue, the anterior chamber is formed and it's very tough. But when you go through the sclera, you need to shut down so that you have hypotony in order to induce a counter pressure of the sclera. So passing through the iris, the line is on. Passing through the sclera, the line is off so that you do the counter pressure. So in conclusion, retroflexion correction is the main key to restore the anatomical shape of the iris and the pupil in cases of iridodialysis more than 3 to 4 clock hours. Here you can see the opposite is antiflexion, and it's very evident here because the posterior surface of the iris, instead of looking to the optic nerve, is looking to the back of the cornea. So I have to correct the retroflexion. It's extremely important. Now I'll stretch it as much as possible. Till I get all my iris tissue. Now there is the sewing technique for the iridodialysis repair. Then I'm doing this passage through the iris, then the sclera, and then I'm exteriorizing a loop. Once I cut the loop here and there, then I have my interrupted sutures like matrix sutures. So here I'm doing the same, feeding my 10-0 preline suture or 9-0 preline suture into the needle, then going through the ciliary border, the real ciliary border of the anti-flexed iris. And then, as you see here, I'm going to exteriorize a loop, then go back again. Here is the loop, go back again to the adjacent hour, pass through the iris, and so on. Now we have combined iridodialysis repair plus pupillary cerclage. Understand the surgical principle, please, in exact order. Number one, correct retroflexion or antiflexion and stretch as much as you can. Number two, attach the ciliary border of the iris because you need to correct the iridodialysis. Lastly, deal with the pupil either by cerclage or better by an hour to an hour approximation as shown before because it's more forgiving. Let us see here. I'm not going to interrupt. I'm not going to interrupt this video because it's showing that I'm correcting the antiflexion, stretching with two hands, now inserting my AC maintainer, stretching the iris as much as I can. So you know that my next step is regaining attachment of the ciliary border of the iris, testing the stretchability of this atrophic iris tissue is not stretchable. So I know that it's better for this case not to do the cerclage, but to do an hour-to-hour approximation. So I'm approximating this end. I'm checking if I can approximate 1 hour to 1 hour, nudging the iris everywhere. Before even fixing my iridodialysis, opening a gutter into the sclera, doing my sewing machine technique as I showed before. Fixing my ciliary border. And now, after fixing my ciliary border, I will start doing 1 hour to 1 hour approximation, fixing this iridodialysis. As you see here, I'm approximating this hour to the adjacent hour, feeding it inside the infusion cannula. Then approximating this hour to this hour. It's not 180 degrees opposite each other. No, they are in one quadrant. Then fixing, then implanting my Yamani lens. And then after centralizing the lens, I will start doing again 1 hour to 1 hour approximation. Why it's forgiving? Because if I have any iridodialysis again, because of this insertion of the suture, then I can retrieve my ciliary border, closing all the defects. And then using my occutome to fashion my pupil according to the code of mu. Okay? So here is again iridodialysis together with traumatic mydriasis. Correct the retroflexion, attach the ciliary border, then do the cerclage. For the sake of time, I'm trying to not to repeat myself, but you got the concept. Now I want to change the pupil location.
Dr. Hazem,
So, yeah.
is there a time frame beyond which it's very difficult to correct an antiflexion or retroflexion?
No, once you get the concept, yeah, you mean that when I'm going to correct it, the more you wait, the more iris tissue is shrunken and fibrosed. So as much as possible, whenever you see a retroflexion or antiflexion, please correct it as early as you can. Now I'm going to close my pupil, but I'm going to change the location of the pupil. So this was described by Ike Ahmed, where you are going to use the endodiathermy, which is used, can you see here? It's inducing shrinkage of the iris tissue. Now I can drag this pupillary border away and draw it around the Myers of the multifocal intraocular lens. So here I'm changing the pupil location by the endodiathermy. I can change the pupil location by excessive suturing. Now you can see here that this pupillary border is shifted downward. Now I'm going to take sutures from the lower part of the pupil extensively to move this pupillary border from downward upward. Look for this suture. Now I dragged the pupil towards the center of the cornea. As you see, now I can use my vitrectomy cutter and I will cut this part of the pupil. So by this way, I did some sort of relocation of my pupil, as you see. And I might use both techniques, the endodiathermy and the cutter at the same time. What are the parameters of the cutter? For the iris, in order to use the vitrectomy as a kind of like a fashioning or kind of like a Photoshop, then you need to do the highest cutting rate with the lowest vacuum. It's extremely important not to take excessive iris tissue. Highest cutting rate with lowest vacuum. And as you see here, I'm closing all my defects. I can change my pupil according to corneal pathology. I don't want to repeat myself. Don't be afraid of this first day post-operative. As you will see corneal edema, you have to keep the patient under cycloplegic in order to decrease the exudates after the iris surgery. For these cases, they are worsening with the pinhole. So if you use the pinhole, if you do iris surgery, you will get it behind the corneal opacity. If there is no improvement with the pinhole, no iris surgery. We can use the pinhole like in any abnormal cornea, flat or RK. For the iris prosthesis, I'm going to skip it because for the sake of time, I want this aphakia case, aniridia case, to be shown. I want to tell you that you have to stain the capsule.
Dr. Hazem, there is a question in the Q&A box. Dr. Ashwin is asking, what would be your approach for traumatic aniridia, which also requires a penetrating keratoplasty along with so
okay.
you probably it will be the same thing.
For this case, I'm going to implant the iris prosthesis inside the bag. So I'm putting the silicone hub and then implanting the iris prosthesis inside the bag. So in order to see it, believe it or not, it's kind of like an octopus when it opens in the anterior chamber. So you have to protect the back of the cornea, and then you have to stain the capsule. If you don't stain the capsule, you will never be able to put it inside the bag. And in order to put it inside the bag, as you saw in the video, you have to do trephination after doing OCT for this, the diameter of the bag itself. But for your question, I'm going to show here that I'm doing it in an open sky, fixing it to the sclera. And once you fix it to the sclera, do not fix it except after reforming the globe. And when you reform the globe, you inject the saline in order to be well centralized. Otherwise, it will be displaced from one side to the other. So for the complications, you might have persistent inflammation, macular edema, retinal detachment, dislocated subluxated iris implant, recurrent bleeding, ciliary body, cornea decompensation, IOL, IOP, transient postoperative hypotony, or moderate increase in the intraocular pressure. What are the complications of iris surgery? You might pull through the iris tissue very carefully and understand the different stretchable behavior, proper passing of the iris in the iris tissue, avoid neovascular iritis by injecting anti-VEGF 2 weeks before, and with a thermomedical history, check the INR PTC, avoid aspirin. This is the most important thing, the take-home message. I want us, all of us, go back home, bring one of those cups of the chains of the Happy Meal, and then put the glove over the cup. Fashion the pupil you want, or fashion any iris defect. And the cover of the cup, it's our cornea. Then for the keratome incision, take 4 keratome incisions in the 4 cardinal oblique diameters. And then while your kids are playing around you in the living room, master the technique of cerclage, master the technique of correcting retroflexion, master the technique of regaining ciliary border attachment in iridodialysis, whatever you want. So we have, all of us, anterior segment surgeons, corneal surgeons, glaucoma surgeons, posterior segment surgeons, all of us, we have to be very unafraid of corneal surgery. We have to train ourselves to deal with the iris tissue as our friend, not as the person who we are afraid of. Well, thank you very much for giving us this opportunity. I hope that we would have been kind of like any adding beneficial information for all the people who taught us many things in India. Actually, many of my mentors are from India, and many of my education, I got it from watching the videos from the guru Indian surgeons. Thank you very much.
Thank you, Dr. Hazem. Fantastic surgeries and wonderful tissue handling. I mean, we were amazed to see the kind of maneuvers you were doing to manage the various iris defects, various dialysis, and doing encerclage, retroflexion, antiflexion. And the best part was the last part, like, I mean, showing the props in the sense that how a person can train himself or herself before actually, venturing into a clinical case. Would you like to share some tips, few, like, maybe a couple of tips for a beginner who is not very familiar with iris reconstruction or iris repair, to be a little careful about handling these tissues?
Well, the most important thing is that during any cataract procedure, why don't you introduce yourself to the iris and introduce the iris to you? Which means that, okay, let me catch the iris with my microcapsular rhexis forceps and try to nudge it in a very controlled way. So I get to introduce myself to the iris, I get to know the iris itself or the behavior itself. Then later on, you go back with this cup, which I showed you, so that you get familiar with all the sutures and all the maneuvers techniques. And always remember the 4 kinds of interrupted sutures for the pupillary border. So for the pupillary border, McCannel was history. Then we have either Ike modification of McCannel. We have Ogua through one wound interiorizing the knot inside the anterior chamber. Or we have Sipser, where I exteriorize the loop outside a wound, and there are 2 wounds which are 180 degrees opposite each other, and then I pull. Or I have a single 4th row of Agrawal, but definitely it should have a posterior IOL behind the iris in order not for the iris to go backward and become disengaged. Those for the pupil. And for the iridodialysis, you have the sewing machine technique, you have the mattress sutures interrupted, and always remember that you have to correct the retroflexion and antiflexion. Once you attach the ciliary border, then you start stretching the tissue, and then you start doing the pupilloplasty. If there is iridodialysis together with traumatic mydriasis, then if you are an experienced surgeon, go for cerclage. If you are a beginner, then go for interrupted sutures. And always remember if the iris tissue is stretchable or the iris tissue is atrophic.
Thank you, Dr. Hazem. And before we wrap up, I would like to invite some comments from many of the CSI panel. Dr. Nikhil or Dr. Vinay, if he's around. Dr. Praveen, you would like to comment before we wrap up?
I mean, nothing but the highest admiration for the variety of surgeries as well as surgical techniques. Dr. Hazem must have taken you several years of putting together this kind of a course with so much focus and being able to transfer teaching and learning to beginners as well as experienced surgeons as well. I'm sure that there's a number of things that I've learned that I can take back. And I think the props that you use and also the fact that you showed how you do this outside the eye, I think is a fantastic message for a lot of budding surgeons. I'm going to use that for my fellows as well to help them learn iris surgery. So thank you very much.
Well, we are really honored actually because we learned, as I said before, we learned many surgical tips and tricks from India. And as I said before, the only thing I consider India is my second country, and the only thing which I don't like about India is the delicious food, because when I go back to Egypt, I gain kind of like 20 kilograms over my weight. So I go to the gym and stay at the gym many days in order to get back to my normal weight.
Thank you, Dr. Hazem and Dr. Rania, for being with us. Thank you, Dr. Gaurav and Dr. Rishi, being part of our, CSI academic initiative. And at the outset also, I would like to thank our CSI panel and the office bearers for, being here, and for the office staff, the backup staff, Shabina and team, to make sure that the streaming is seamless. And at the same time, I would also like to thank your technical support person who made it sure that
I would like to thank Shabina. Shabina is the hidden soldier who's exerting an extra dynamic maneuver and extra dynamic effort for the Cornea Society of India and for all the events like the KERAKONNECT and everything. Thank you very much, Shabina.
Thank you
Shabina,
very
you are
much.
getting an
It's an honor.
international gold medal.
It's an honor. Thank you so much.
So thank you very much, Dr. Hazem and Dr. Rania, for sparing your time, and especially when you had your departmental corneal surgery meeting today. So it must be really a marathon effort for you. Thank you
It
so
was
much for
our
being
honor.
with us. And note it, we will not spare you. We are going to have you for advanced cases of iris repair again at some point of time. So thank you everyone for being here.
Thank you so much.
And
Thanks, Dr. Paras, and thank you everybody for inviting me. It was truly a masterclass. Thank you.
Thank
Thank
you
good
very
night,
much.
everyone.
you.
Yeah.
Bye.
Bye.